Hydrocephalus is a condition in which there is an accumulation of cerebrospinal fluid, CSF, within the brain. This typically causes increased pressure inside the skull. Older people may have headaches, double vision, poor balance, urinary incontinence, personality changes, or mental impairment. In babies there may be a rapid increase in head size. Other symptoms may include vomiting, sleepiness, seizures, and downward pointing of the eyes. Hydrocephalus can occur due to birth defects or be acquired later in life. Associated birth defects include neural tube defects and those that result in aqueductal stenosis. Other causes include meningitis, brain tumors, traumatic brain injury, intraventricular hemorrhage, and subarachnoid hemorrhage. There are 4 types of hydrocephalus: communicating, non-communicating, ex vacuo, and normal pressure. Diagnosis is typically made by examination and medical imaging. Hydrocephalus is typically treated by the surgical placement of a shunt system. A procedure called a third ventriculostomy may be an option in a few people. Complications from shunts may include overdrainage, underdrainage, mechanical failure, infection, or obstruction. This may require replacement. Outcomes are variable, however, many live normal lives. Without treatment, death may occur. About 1 to 2 per 1,000 newborns have hydrocephalus. Rates in the developing world may be more. Normal pressure hydrocephalus is estimated to affect about 5 per 100,000 people, with rates increasing with age. Description of hydrocephalus by Hippocrates date back more than 2,000 years. The word hydrocephalus is from Greek hydro, meaning water, and cephalos, meaning head. Signs and symptoms. The clinical presentation of hydrocephalus varies with chronicity. Acute dilatation of the ventricular system is more likely to manifest with the nonspecific signs and symptoms of increased intracranial pressure. By contrast, chronic dilatation, especially in the elderly population, may have a more insidious onset, presenting, for instance, with Hakim's triad, Adam's triad. Symptoms of increased intracranial pressure may include headaches, vomiting, nausea, papilledema, sleepiness or coma. Elevated intracranial pressure may result in uncal or tonsillar herniation, with resulting life-threatening brain stem compression. Hakim's triad of gait instability, urinary incontinence, and dementia is a relatively typical manifestation of the distinct entity normal pressure hydrocephalus, NPH. Focal neurological deficits may also occur, such as abducens nerve palsy and vertical gaze palsy, Peritoneal syndrome due to compression of the quadrigeminal plate, where the neural centers coordinating the conjugated vertical eye movement are located. The symptoms depend on the cause of the blockage, the person's age, and how much brain tissue has been damaged by the swelling. In infants with hydrocephalus, CSF builds up in the central nervous system, causing the fontanelle, soft spot, to bulge and the head to be larger than expected. Early symptoms may also include eyes that appear to gaze downward, irritability, seizures, separated sutures, sleepiness, vomiting. Symptoms that may occur in older children can include brief, shrill, high-pitched cry, changes in personality, memory, or the ability to reason or think, changes in facial appearance and eye spacing, crossed eyes or uncontrolled eye movements, difficulty feeding, excessive sleepiness, headache, irritability, poor temper control, loss of bladder control, urinary incontinence, loss of coordination and trouble walking, muscle spasticity, spasm, slow growth, child 0–5 years, slow or restricted movement, vomiting. Because hydrocephalus can injure the brain, thought and behavior may be adversely affected. Learning disabilities including short-term memory loss are common among those with hydrocephalus, who tend to score better on verbal IQ than on performance IQ, which is thought to reflect the distribution of nerve damage to the brain. However, the severity of hydrocephalus can differ considerably between individuals, and some are of average or above average intelligence. Someone with hydrocephalus may have coordination and visual problems, problems with coordination, or may be clumsy. They may reach puberty earlier than the average child, see precocious puberty. About 1 in 4 develops epilepsy. Cause: congenital. 1-year-old girl with hydrocephalus showing sunset eyes, before shunt surgery. Congenital hydrocephalus is present in the infant prior to birth, meaning the fetus developed hydrocephalus in utero during fetal development. The most common cause of congenital hydrocephalus is aqueductal stenosis. Aqueductal stenosis occurs when the narrow passage between the third and fourth ventricles in the brain is blocked or too narrow to allow sufficient cerebral spinal fluid to drain. Fluid accumulates in the upper ventricles, causing hydrocephalus. Other causes of congenital hydrocephalus include neural tube defects, arachnoid cysts, Dandy-Walker syndrome, and Arnold-Chiari malformation. The cranial bones fuse by the end of the third year of life. For head enlargement to occur, hydrocephalus must occur before then. The causes are usually genetic but can also be acquired and usually occur within the first few months of life, which include 1. Intraventricular matrix hemorrhages in premature infants, 2. Infections, 3. Type 2 Arnold-Chiari malformation, 4. Aqueduct atresia and stenosis, and 5. Dandy-Walker malformation. In newborns and toddlers with hydrocephalus, the head circumference is enlarged rapidly and soon surpasses the 97th percentile. Since the skull bones have not yet firmly joined together, bulging, firm anterior and posterior fontanelles may be present even when the patient is in an upright position. The infant exhibits fretfulness, poor feeding, and frequent vomiting. As the hydrocephalus progresses, torpor sets in, and the infant shows lack of interest in his surroundings. Later on, the upper eyelids become retracted and the eyes are turned downwards, sunset eyes, due to hydrocephalic pressure on the mesencephalic tegmentum and paralysis of upward gaze. Movements become weak and the arms may become tremulous. Papilledema is absent but there may be a reduction of vision. The head becomes so enlarged that the child may eventually be bedridden. About 80 to 90% of fetuses or newborn infants with spina bifida often associated with meningocele or myelomeningocele develop hydrocephalus. Acquired. This condition is acquired as a consequence of CNS infections, meningitis, brain tumors, head trauma, toxoplasmosis, intracranial hemorrhage, subarachnoid or intraparenchymal, and is usually painful. Type. The cause of hydrocephalus is not known with certainty and is probably multifactorial. It may be caused by impaired cerebrospinal fluid, CSF, flow, reabsorption, or excessive CSF production. Obstruction to CSF flow hinders the free passage of cerebrospinal fluid through the ventricular system and subarachnoid space, e.g., stenosis of the cerebral aqueduct or obstruction of the interventricular foramina, secondary to tumors, hemorrhages, infections or congenital malformations, and can cause increases in central nervous system pressure. Hydrocephalus can also be caused by overproduction of cerebrospinal fluid, relative obstruction, e.g., choroid plexus papilloma, villus hypertrophy. Bilateral ureteric obstruction is a rare, but reported, cause of hydrocephalus. Based on its underlying mechanisms, hydrocephalus can be classified into communicating and non-communicating, obstructive. Both forms can be either congenital or acquired. Communicating. Communicating hydrocephalus, also known as non-obstructive hydrocephalus, is caused by impaired cerebrospinal fluid reabsorption in the absence of any CSF flow obstruction between the ventricles and subarachnoid space. It has been theorized that this is due to functional impairment of the arachnoidal granulations, also called arachnoid granulations or Pacchione's granulations, which are located along the superior sagittal sinus and is the site of cerebrospinal fluid reabsorption back into the venous system. Various neurologic conditions may result in communicating hydrocephalus, including subarachnoid/intraventricular hemorrhage, meningitis, and congenital absence of arachnoid villi. Scarring and fibrosis of the subarachnoid space following infectious, inflammatory, or hemorrhagic events can also prevent resorption of CSF, causing diffuse ventricular dilatation. Non-communicating hydrocephalus, or obstructive hydrocephalus, is caused by a CSF flow obstruction. Foramen of Monro obstruction may lead to dilation of one or, if large enough, e.g., in colloid cyst, both lateral ventricles. The aqueduct of Sylvius, normally narrow to begin with, may be obstructed by a number of genetically or acquired lesions, e.g., atresia, ependymitis, hemorrhage, tumor, and lead to dilation of both lateral ventricles as well as the third ventricle. Fourth ventricle obstruction will lead to dilatation of the aqueduct as well as the lateral and third ventricles, e.g., Chiari malformation. The foramina of Luschka and foramen of Magendie may be obstructed due to congenital malformation, e.g., Dandy-Walker malformation. Other normal pressure hydrocephalus, NPH, is a particular form of communicating hydrocephalus, characterized by enlarged cerebral ventricles, with only intermittently elevated cerebrospinal fluid pressure. The diagnosis of NPH can be established only with the help of continuous intraventricular pressure recordings, over 24 hours or even longer, since more often than not instant measurements yield normal pressure values. Dynamic compliance studies may be also helpful. Altered compliance, elasticity, of the ventricular walls, as well as increased viscosity of the cerebrospinal fluid, may play a role in the pathogenesis of normal pressure hydrocephalus. Hydrocephalus ex vacuo also refers to an enlargement of cerebral ventricles and subarachnoid spaces, and is usually due to brain atrophy, as it occurs in dementias, post-traumatic brain injuries and even in some psychiatric disorders, such as schizophrenia. As opposed to hydrocephalus, this is a compensatory enlargement of the CSF spaces in response to brain parenchyma loss. It is not the result of increased CSF pressure. Mechanism: hydrocephalus is usually due to blockage of cerebrospinal fluid, CSF, outflow in the ventricles or in the subarachnoid space over the brain. In a person without hydrocephalus, CSF continuously circulates through the brain, its ventricles, and the spinal cord and is continuously drained away into the circulatory system. Alternatively, the condition may result from an overproduction of the CSF, from a congenital malformation blocking normal drainage of the fluid, or from complications of head injuries or infections. Compression of the brain by the accumulating fluid eventually may cause neurological symptoms such as convulsions, intellectual disability, and epileptic seizures. These signs occur sooner in adults, whose skulls are no longer able to expand to accommodate the increasing fluid volume within. Fetuses, infants, and young children with hydrocephalus typically have an abnormally large head, excluding the face, because the pressure of the fluid causes the individual skull bones which have yet to fuse to bulge outward at their juncture points. Another medical sign, in infants, is a characteristic fixed downward gaze with whites of the eyes showing above the iris, as though the infant were trying to examine its own lower eyelids. The elevated intracranial pressure may cause compression of the brain, leading to brain damage and other complications. Conditions among affected individuals vary widely. If the foramina of the fourth ventricle or the cerebral aqueduct are blocked, cerebrospinal fluid, CSF, can accumulate within the ventricles. This condition is called internal hydrocephalus and it results in increased CSF pressure. The production of CSF continues, even when the passages that normally allow it to exit the brain are blocked. Consequently, fluid builds inside the brain, causing pressure that dilates the ventricles and compresses the nervous tissue. Compression of the nervous tissue usually results in irreversible brain damage. If the skull bones are not completely ossified when the hydrocephalus occurs, the pressure may also severely enlarge the head. The cerebral aqueduct may be blocked at the time of birth or may become blocked later in life because of a tumor growing in the brainstem. Treatment: hydrocephalus can be successfully treated by placing a drainage tube, shunt, between the brain ventricles and abdominal cavity. There is some risk of infection being introduced into the brain through these shunts, however, and the shunts must be replaced as the person grows. A subarachnoid hemorrhage may block the return of CSF to the circulation. This should be distinguished from external hydrocephalus. This is a condition generally seen in infants and involving enlarged fluid spaces or subarachnoid spaces around the outside of the brain. This is generally a benign condition that resolves spontaneously by 2 years of age. Greenberg, Handbook of Neurosurgery, 5th edition, pg 174. Imaging studies and a good medical history can help to differentiate external hydrocephalus from subdural hemorrhages or symptomatic chronic extra-axial fluid collections which are accompanied by vomiting, headaches and seizures. Hydrocephalus treatment is surgical, creating a way for the excess fluid to drain away. In the short term, an external ventricular drain, EVD, also known as an extraventricular drain or ventriculostomy, provides relief for urgent/emergent care. In the long term, some patients will need any of various types of cerebral shunt. It involves the placement of a ventricular catheter, a tube made of celastic, into the cerebral ventricles to bypass the flow obstruction/malfunctioning arachnoidal granulations and drain the excess fluid into other body cavities, from where it can be resorbed. Most shunts drain the fluid into the peritoneal cavity, ventriculoperitoneal shunt, but alternative sites include the right atrium, ventriculoatrial shunt, pleural cavity, ventriculopleural shunt, and gallbladder. A shunt system can also be placed in the lumbar space of the spine and have the CSF redirected to the peritoneal cavity, lumbar peritoneal shunt. An alternative treatment for obstructive hydrocephalus in selected patients is the endoscopic third ventriculostomy, ETV, whereby a surgically created opening in the floor of the third ventricle allows the CSF to flow directly to the basal cisterns, thereby shortcutting any obstruction, as in aqueductal stenosis. This may or may not be appropriate based on individual anatomy. For infants, ETV is sometimes combined with choroid plexus cauterization, which reduces the amount of cerebrospinal fluid produced by the brain. The technique, known as ETV/CPC, was pioneered in Uganda by neurosurgeon Ben Whorf and is now in use in several U.S. hospitals. Shunt complication. Examples of possible complications include shunt malfunction, shunt failure, and shunt infection, along with infection of the shunt tract following surgery. The most common reason for shunt failure is infection of the shunt tract. Although a shunt generally works well, it may stop working if it disconnects, becomes blocked, clogged, infected, or it is outgrown. If this happens, the cerebrospinal fluid will begin to accumulate again and a number of physical symptoms will develop: headaches, nausea, vomiting, photophobia/light sensitivity, some extremely serious, like seizures. The shunt failure rate is also relatively high. Of the 40,000 surgeries performed annually to treat hydrocephalus, only 30% are a patient's first surgery, and it is not uncommon for patients to have multiple shunt revisions within their lifetime. Another complication can occur when CSF drains more rapidly than it is produced by the choroid plexus, causing symptoms: listlessness, severe headaches, irritability, light sensitivity, auditory hyperesthesia, sound sensitivity, nausea, vomiting, dizziness, vertigo, migraines, seizures, a change in personality, weakness in the arms or legs, strabismus, and double vision, to appear when the patient is vertical. If the patient lies down, the symptoms usually vanish quickly. A CT scan may or may not show any change in ventricle size, particularly if the patient has a history of slit-like ventricles. Difficulty in diagnosing overdrainage can make treatment of this complication particularly frustrating for patients and their families. Resistance to traditional analgesic pharmacological therapy may also be a sign of shunt overdrainage or failure. The diagnosis of cerebrospinal fluid buildup is complex and requires specialist expertise. Diagnosis of the particular complication usually depends on when the symptoms appear, that is, whether symptoms occur when the patient is upright or in a prone position, with the head at roughly the same level as the feet. Developing countries. Because the shunt systems are too expensive for most people in developing countries, such people often die without getting a shunt. Worse, the rate of revision in shunt systems adds to the cost of shunting many times. Looking at this point, a study compares shunt systems and highlights the role of low-cost shunt systems in most of the developing countries. It compares the COBRA shunt system to shunt systems from developed countries. History. References to hydrocephalic skulls can be found in ancient Egyptian medical literature from 2500 BC to 500 AD. Hydrocephalus was described more clearly by the ancient Greek physician Hippocrates in the 4th century BC, while a more accurate description was later given by the Roman physician Galen in the 2nd century AD. The first clinical description of an operative procedure for hydrocephalus appears in the Al-Tasrif, 1000 AD, by the Arab surgeon, Abul Qasis, who clearly described the evacuation of superficial intracranial fluid in hydrocephalic children. He described it in his chapter on neurosurgical disease, describing infantile hydrocephalus as being caused by mechanical compression. He wrote, "The skull of a newborn baby is often full of liquid, either because the matron has compressed it excessively or for other, unknown reasons. The volume of the skull then increases daily, so that the bones of the skull fail to close. In this case, we must open the middle of the skull in 3 places, make the liquid flow out, then close the wound and tighten the skull with a bandage." In 1881, a few years after the landmark study of Retzius and Key, Karl Wernicke pioneered sterile ventricular puncture and external drainage of cerebrospinal fluid for the treatment of hydrocephalus. It remained an intractable condition until the 20th century, when shunts and other neurosurgical treatment modalities were developed. It is a lesser-known medical condition, relatively little research is conducted to improve treatment, and there is still no cure. In developing countries, the condition often goes untreated at birth. Before birth, the condition is difficult to diagnose, and there is limited access to medical treatment. However, when head swelling is prominent, children are taken at great expense for treatment. By then, brain tissue is undeveloped and neurosurgery is rare and difficult. Children more commonly live with undeveloped brain tissue and consequential intellectual disability. Society and culture. Awareness campaign. September was designated National Hydrocephalus Awareness Month in July 2009 by the U.S. Congress in H.R. 373. The resolution campaign is due in part to the advocacy work of the Pediatric Hydrocephalus Foundation, incorporated prior to July 2009. There was no awareness month for this condition. Many of the hydrocephalus organizations within the United States use various ribbon designs as a part of their awareness and fundraising activities. Exceptional case. One exceptional case of hydrocephalus was a man whose brain shrank to a thin sheet of tissue, due to a buildup of cerebrospinal fluid in his skull. As a child, the man had a shunt, but it was removed when he was 14. In July 2007, at age 44, he went to a hospital due to mild weakness in his left leg. When doctors learned of the man's medical history, they performed a computed tomography, CT, scan and magnetic resonance imaging, MRI, scan, and were astonished to see massive enlargement of the lateral ventricles in the skull. Dr. Lionel Furiat of Hôpital de la Timone in Marseille said, "The images were most unusual, the brain was virtually absent." Intelligence tests showed the patient had an IQ of 75, below the average score of 100. This would be considered borderline intellectual functioning, just above what would be officially considered mentally challenged. The patient was a married father of 2 children, and worked as a civil servant, leading an at least superficially normal life, despite having enlarged ventricles with a decreased volume of brain tissue. "What I find amazing to this day is how the brain can deal with something which you think should not be compatible with life," commented Dr. Max Muenk, a pediatric brain defects specialist at the National Human Genome Research Institute. "If something happens very slowly over quite some time, maybe over decades, the different parts of the brain take up functions that would normally be done by the part that is pushed to the side." Notable cases. Author Sherman Alexie, born with the condition, wrote about it in his semi-autobiographical junior fiction novel The Absolutely True Diary of a Part-Time Indian. Prince William, Duke of Gloucester, probably contracted meningitis at birth, which resulted in this condition.
Please subscribe and thanks for watching.